So we start with pharmacology, and chapter 1 is pharmacokinetics. In kinetics, we have two things: kinetics and dynamics. Dynamics means the drug act on the body, right? And kinetics means effect of body on drug, right? Then we have four things: ADME, absorption, distribution, metabolism, excretion. Four things are there, right? So in this, we have to see first that what is acidic, what is basic, right? So at the end, the main thing is like acids will be like we have acid and acid. If they two are there, then that means that will be lipid soluble, and that means it will be lipid soluble, and that will be non-ionized, so it will cross, right? Whenever we have basics, that will be same non-ionized lipid soluble, that will also cross. But whenever you have acid basic or basic acid, that will be ionized, that will be water soluble, that will not cross, right? So lipid soluble is the one which is preferred one, right? And we have bioavailability. It means that the one which reaches the systemic circulation. Okay, like for example, you have 100, then it will go 30 into the liver, then it will be more, then again it will go then 80 and 50. So the one which reaches the systemic circulation, that is the bioavailability. And the one which will remain in between, that is the first pass metabolism, right? Then first pass metabolism, in this it will divide into like bioavailability. If your first pass metabolism increase, then bioavailability will decrease. If it is decreasing, then so that will be like inverse proportion, right? First pass metabolism is proportional to absorption by bioavailability, right? Then we have two things in this. What do we have is we have curve and we have Tmax, right? Then we have a Cmax, which is maximum concentration of drugs. Okay, so what usually they ask is area under curve. Okay, that means the total drug coming into body. Okay, that means what? Extent of absorption. This is what we need to remember: extent of absorption, which is there in the area under curve, right? Yeah, and T max will be the rate. So this is what we have to remember, right? They can ask fluoroquinolone with highest oral bioavailability, that will be levofloxacin, right? Then we have pharmacokinetics. In kinetics, we have what? Lipid and plasma. Lipid soluble, plasma binding protein. Then we have important stuff. In lipid solubility, what? Pharmaco. Now we are talking about kinetics. So VD is amount. VD is volume of distribution is amount by plasma concentration. So this is just a formula which we need to remember. So in lipid solubility, we have lipid soluble and water soluble. Lipid soluble means what? Lipid soluble which will cross. So it will cross, that's why it will have more distribution. Water soluble will not cross, so low distribution. Then we have plasma binding protein. Okay, so in this it will be like inverse. So like plasma binding protein, if it increases, then distribution will decrease, and if that decreases, then distribution will increase, right? Then we have two things: albumin and alpha acid glycoprotein, right? So in this, what do we have is, what we can see is yes, we can see here drugs. We have acidic drug and basic drugs. So in acidic drugs, in albumin, A means albumin, A is acidic drugs, we can have aspirin, we can have barbiturates. And in second one, we can have basic drugs, right? That will be atropine, morphine, like this. So what main thing is very high distribution, sequestration in body tissue. The more it will be there, distribution, okay, the more it will be there in the tissues, right? So now let's talk about plasma binding protein in this first distribution. So the more will the distribution, the less will be the volume, right? Which I told, right? More distribution, more plasma PPP, okay, plasma binding protein, less will the distribution, right? So this we already told, because more plasma will be there in the blood, so that will not go to the tissue, so there will be less distribution, right? Now is the displacement. Displacement is the one, like there will be two drugs, one will win and one will not be there, and one will lose, right? So that's how it will displace the drugs. Then we will have duration. All DDD will be there, distribution, displacing. Then duration of disease, that will be due to storage, due to long duration of the action. Okay, then we have dialysis. Dialysis, it is the one which can be removed by dialysis drug. In this we will have two things: low volume of drug and low plasma protein binding, right? Both will be low. In this we will have drugs, that will be three, which will be MLA. M is methanol, L is lithium, A is aspirin. Okay, lithium, it is the one which is treated by dialysis, right? So lithium is the one which is treated by dialysis. So this question has already come. Okay, now question could be like high plasma protein binding of a drug result in what? It will result in decreased glomerular filtration. Then there was a drug in which question in which they asked grave disease, hyperthyroidism, okay, aplasia cutis. So which drug will be most likely drug implicated for teratogenic effect is carbimazole. Okay. Then we have two things: loading dose, maintenance dose. Loading is what? VD into target PC. Okay, and maintenance is what? CL into target PC, right? So loading is there na, so VD into target PC, D to D, VD, right? In maintenance we have CL will be clearance into target PC, right? That's how we can see. Then we have acetylation. In this we have ship drugs, sulfonamide, okay, hydralazine, INH, and prokinamide. These are all acetylation. Now come third, pharmacokinetics. In this it will be phase 1 and phase 2 reaction. Phase 1 is catabolic, phase 2 anabolic. In phase 1 we will have oxidation, reduction, hydrolase, cyclization, deamination. Drug is broken most commonly. So most commonly oxidation, which is phase 1 catabolic. In anabolic, what do we have is when substrate in this it will be like, it is also called as conjugation. In this it will be glucuronide, glutathione, glycine. And regarding acetylation, question has come. Okay, all GGG will be there. Then acetylation, methylation, sulfonation, all these things will be there. Which of the following is not a product? So product will be primidone. So rest products are 5-fluorouracil, proguanil, sunaldehyde, like this. Then we have two things: inducers and inhibitors. Okay, inducers means GPRS, cell phone. Inhibitors means vitamin K can't cause inhibition, enzyme inhibition, right? And so in inducers we have GPRS, cell phone. G means, this all question has come. G is greaseprofulvin. P is phenytoin. Okay, R means rifampicin. This question has come. S is smoking. Okay, C means cell means CBZ. Phone is phenobarbital. So this was the inducer. Then inhibitors, vitamin K can't cause enzyme inhibition. Vitamin K means valproate. K means ketoconazole. Can't means cimetidine. Cause means ciprofloxacin. Enzyme means erythromycin. I means inhibition isoniazid. Like this it will be there, right? So now let's see the enzymes, CYP enzymes. Okay, so what is the CYP? So CYP is like CYP3A41 normal culture, right? So now let's see CYP2D6. Okay, 2D6 means 2 means beta blocker, so that will be 2. Okay, D means depression, that will be antidepressant. 6 means sex, that will be anti-arrhythmia, except 1 which will be amiodarone. So CYP2D6, 2 is beta blocker, D is depression, and 6 is sex, that is antidepressant, right? Then we have important examples of drug, that will be CYP3A4. CYP2D6 for that. Now 3A4. Okay, that will be CT scan. CYP3A4 CT scan. In this it will be what? CT means cyclosporidine, CCB. T is tacrolimus. Okay, CT scan. S is statin. Then C means cisapride, acetamazole. Okay, terfenide, right? So all this C will be there. This will, all this C will form what? QT prolongation, that will be in the ECG. And A is amiodarone, N is navirs, right? Cyclosporin, CCB. CT tacrolimus, S is statin. Okay, C means cisapride, all this. Then A is amiodarone and navir. Okay, now you have CYP2C9. Okay, CYP2C9. C means what? C is clotting antagonist, right? And then what do we have is warfarin. So 9 will be warfarin. Okay, CYP2C9. 2 will be 2. C is what? Clotting factor, warfarin. 9 is phenytoin. Then we have CYP2C19. Okay, C1 is there, right? So C1 will be clopidogrel. We take 1SL clopidogrel, right? Then we have clarithromycin, right? Then we move further, pharmacokinetics. In this it will be like GFR, right? So filtration is proportional to ppb, plasma binding protein. Okay, this is inversely proportional. And sorry. And then we have filtration. Okay, filtration 125 milliliter per minute, this is normal. Then we have tubular reabsorption, that will be only for the ALS. Okay, lipid soluble, not water soluble. Okay, in this, if drug and media are same, that will be absorbed, otherwise not. Okay, so there is a question: patient on lithium therapy developed hypertension. He was on thiazide for hypertension. After a few days he developed tremors and other symptoms of lithium toxicity. So explain the mechanism. It will be thiazides which increase the tubular reabsorption of lithium. thiazides are there which go into the tubular reabsorption and they reabsorb the lithium. Okay, then yeah, in the tubular reabsorption it will be like plasma there, drug is there, treat acidic drug poisoning by making urine alkaline. Okay, lipid soluble, for example aspirin, barbiturates. Okay, then we have tubular secretion. In this it will be like reassured. Okay, and in this it will be penicillin go out by what, pumps or inhibitor. So in this just you need to remember one thing is in tubular secretion it will be like penicillin or probenecid, right? Penicillin is a short acting drug, and in this we add probenecid to make penicillin long acting, right? For plasma level monitoring, lithium estimation is 12 hours after the last dose. Okay, in order to, if we want to calculate plasma level. Okay, then we have half life. In the half life it will be like T half is 6 hours, after 1 day it will be 24 hours, then it will be 6.25. Okay, like this it will go, right? So first of all you 100, then again T half 50, 25, 12.5, answer will then 6.5. If they ask about after 8 hours what it will be, okay, so after 2 hours you can do, right? So the mean, now let's see the formula. In formula it's like T half is the volume of distribution V half. Okay, or it's 1 by clearance, so we can see like T half equal to 0.63 into VD by clearance. Okay, or we can see T half is equal to 0.693 by K, right? So all the advantages of enteric coated tablets we can see, like it protects from stomach, it absorbs acid labile products, but the one thing is it increases the half-life of the drug. This is the one which is wrong, it does not increase the half-life, right? Let's go ahead and see fraction. We have first order kinetics, second zero order kinetics. First is the one which is fraction. In this the fraction is constant, rate of elimination will be equal proportional to plasma concentration. In zero order it will be amount is constant, right? So in zero order kinetics, see all are usually majority first order kinetics, but we have some which follows zero order kinetics, right? So we have 0 watt, right? 0 means zero order kinetics, watt power. Watt means warfarin, A is alcohol or aspirin, then we have T theophylline, tolbutamide, then we have P is phenytoin, that is which is epilepsy, right? Warfarin, alcohol or aspirin, theophylline, tolbutamine, P is power, which is phenytoin. Okay, activity. Activity we have three things. See, if we go on a zero level, then it will be antagonist, right? 0. If you go ahead, then it will be agonist, then partial agonist, then antagonist, and then inverse agonist, right? Agonist, partial agonist, antagonist, and inverse agonist. Like this it will be there, right? So we have then we can see the activity. Okay, so based on the activity we can see like the maximum will be in the agonist. Okay, then it will be like submaxillar. Okay, we are in the partial, and in antagonist we have no action, and inverse we have negative action. So like this we can see. Now let's see the ionotropic receptors. Okay, in this it will be there in the three things. It's the fastest acting receptor, and it will be present in three things. Okay, brain, and there will be 2 brain, 2 nerves, and 3 serotonin, right? So 2 brain means 2 things will be there, GABA and NMDA receptor, one inhibitory, one stimulatory, GABA and NMDA receptor, right? And then you have 2 brain, and then you have 2 nerves, that will be NN and NM. Then you will have 3 serotonin, which is 5-HT3 receptors, right? So this is what the one is ionotropic receptor. After ionotropic we have enzymatic reactors. So ionotropic and enzymatic, what do we have is we have cytokines and we have PEG. Okay, in the cytokines what do we have here is cytokines we have IL, okay, TNF alpha, INF. Okay, we have IL, TNF alpha, INF. Second we have hormones which is PEG, which is prolactin, insulin, and growth hormone. Okay, so drug which act through tyrosine kinase receptor is what? Insulin. So this question is already come in the enzymatic reactors, right? Then we have is G coupled protein receptors. Okay, in G coupled protein receptors what do we have is we have GS, we have then we have G1, then we have GG, right? So like this we have. So in this what we have to see, the main is G protein coupled receptor. In this it will be C, 3 things will be there. What does it activate is usually like CAMP, okay, then calcium ion, okay, then other ions which are active. Okay, and in this it will be, this will increase the calcium, CAMP and ion channel. So this is the main which you need to remember. Okay, if they ask GS, then it will increase CAMP. If they ask GI, then it will decrease CAMP. Okay, S will increase, I will inhibit. So okay, this you need to know. And then comes intracellular. In intracellular we have two things. It will be cytoplasmic or nuclear. So CD सात, right? सैटरडे को इंट्रा बैठ के CD देखते हैं लाइक सेल के अंदर. सो लाइक द होल आइडिया वॉज वी हैव साइटो मीन्स CD, न्यूक्लियस मीन्स सेट. साइटो मीन्स CD is corticosteroids, mineral corticosteroids, glucocorticoids. Then we have CT. Okay, then D means vitamin D. Cytoplasmic means so corticosteroids, and then we have vitamin D. And in the nuclear we have what? In the nuclear we have SET. Okay, sex hormones we have estrogen, progesterone, testosterone. Okay, SAT. A is androgen, then T is what? Thyroid hormones, T3 and T4. Like this we have. Then we have curve, DRC curve, which is hyperbola. Okay, then we have log DRC curve, which is only shape sigmoid. Log DRC is only sigmoid. And then we have DRC, which is hyperbola. This is hyperbola, this is sigmoid, right? Then we have HELP. In HELP, what do we have is just see height and left, right? Height is efficacy and left will be the potency. Okay, this is done. Now let's see the drugs. So we have two things, graded and quantal, right? So graded is the one which is grade. So usually individuals are the one which get grades, right? So that will be one individual. But when this is quantal is the one which will be different individuals. That might be in the animals, right? Quantal means quantity, right? So that's how we see it. Then we have two things, therapeutic and lethal effect. Okay, in this therapeutic, this question has come. Therapeutic effect is the margin of what? Safety of a drug. Okay, margin of safety. Then we have is drug and receptor, and then we have therapeutic index, that will be LD50 by ED50. Okay, LD50 means any animal die at this dose, LD50, and the expected effect at this doses will be ED, right? So LD50 is what? Therapeutic effect, right? So this is how we can see. And yeah, this is done. And then we can go ahead and we can see the trials. Okay, in trials we need to know one thing. It will be, they can ask you that which one is the true. So like randomized controlled trial in patient are done in phase 2. So we have 4 phases. Okay, phase 1, phase 2, phase 3 and phase 4. In phase 1 it will be healthy but non-effective, right? It will be just healthy but like there will be no efficacy, right? Healthy people only. In phase 2 what do we have is, in phase 2 it will be like efficacy done for the first time. Okay, so do not confuse with it. So in first it was the maximum tolerable dose, right? But it will be healthy not effective. They will ask you what the first efficacy time or clinical trial, that will be phase 2. And when they will ask the confirmatory efficacy, that will be phase 3. Okay, then we have NDA after phase 3. Okay, then we have phase 4 after drug come into market, that will be a post market. Okay, to know rare and long term side effects. This is what we can see. Okay, so in phase 1 it's healthy non-effective. In phase 2 it's first time efficacy. In phase 3 it will be confirmatory efficacy. Then you have NDA. Then you have part 4 is the one after drug has come into the market. Okay, then you have phase 1, phase 2, phase 3. Phase 1 is the one which is open. Okay, phase 2 is the one which is single, open, single and double. Okay, phase 1, 2, 3. But efficacy first will be seen in phase 2. Okay, and phase 2 is the one which will be the single. Okay, so in this it will be a maximum risk of failure because there will be first time of efficacy we will see. And if they ask you the best one, that will be the phase 3, that will be double. So open, single, double will be the best to confirm, right? Then we can see P-drug effect, that will be step, safety, tolerability, efficacy, price. Then you have fixed dose recombination, that will be adverse effect. Okay, extent is AUC. Okay, this is how we can see it. And then what we can do is yeah, so I think, yeah, now we have only some of the drugs which we can see in the pregnancy. See in pregnancy, paracetamol is safe, which is the A drug, and then A, B, C, D, then come X. X is the one which is contraindicated, that is thalidomide, which is fecomalia, right? Then we have safe and unsafe. So which of them are the safe in pregnancy? In hypertension we can give labetalol, methyldopan, but in unsafe will be ACE, ARB. Okay, then we have hyperthyroidism. In this it will be like PTU and PPU, and that will be like disadvantage of aplasia cutis and unsafe will be carbimazole, methimazole, like this. Epilepsy means L will be there to lamotrigine, levetiracetam will be there, and unsafe will be valproate. Bipolar, in bipolar what we have? We have antipsychotic, okay, and another unsafe will be lithium, okay, and we avoid all the stuff. Then we have antimicrobial. In antimicrobial we have PCM, penicillin, cephalosporin, macrolide, okay. Phenytoin can't cross placenta, and then 80F will be there, right, which will be unsafe. Aminoglycoside tetracycline fluoroquinolone, right. So I told you about this. Placebo will be the sham surgery, okay, and pharmacovigilance will be the monitoring of drug safety. BS criteria is what? To reduce the inappropriate medicine followed by physician. Then we have P-glycoprotein, that will be MDR1, physiological antagonism in different receptor opposite rephase, right. Competitive is the one which will increase the competition, and in this there will be no Vmax, and non-competitive will be like that will decrease. Competitive means cross, this will cross, and non-competitive means from the same place it will go, but it will not cross. Then it will be like it will decrease the Vmax, right, and uncompetitive means both will decrease, right. So like this it will be there. Then we have drug label, okay, that will be like OTC or Schedule X. Then we can have storage. In cold storage it will be like 8 to 25. This question is asked, okay. In cool it is 8 to 25. In cold it is 2 to 8, right, okay. And then we can see the prescription, how do we write, okay. So all these things we must know. And which drug is sold only by the retailer, that will be Schedule H, that will be thalidomide, right. So and Schedule X will be the ketamine. So our first chapter of pharmacology is done, okay. Thank you.